Okay? So those things will increase dead space. Anything else increase the PCO2? So dead space leads to an increased PCO2. Is there anything else that might lead to an increased need for a minute ventilation? Another thing is nutritional support. So this is a very wide encompassing lecture if you haven't figured that out. We talk about a lot of issues here. So how does nutrition, or does nutrition have any effect on any of this?
Yeah, higher fats, I think, produces, is that right? The fat content relatively produces how much carbon dioxide you produce breakdown.
Okay, so when you look, what is that relationship called? Between substrates and CO2 production. It's called the respiratory quotient,
yes.
Right? Okay, so the respiratory quotient. What is that? What is that? That's the. Thank you. I would have figured it out as I kept talking through this, because I would have seen it, but thanks for correcting me early. Okay, so you have fat, protein, and carbohydrate, right? Three major substrates. Respiratory quotient for each of these is different. So what does that mean? That means for every molecule, mole, whatever, of a unit of oxygen, you're going to produce a certain amount of CO2. And depending on the substrate, that's going to vary. So what's the normal respiratory quotient? Overall, right? We eat a mixture of foods, right?
0.9 or something.
Okay, usually they take it at 0.8. Why 0.8? It's probably the typical high-fat, high-protein American diet is 0.8, okay? But if you were only going to eat one of these and not the others, it would change. Or if you change the proportion, it would change of fat to protein to carbohydrate. So if you were, so the most efficient substrate is what?
Fat.
Fat. Okay, it's the highest calories, and for every molecule of oxygen or mole or whatever of oxygen, how much CO2 is produced? It's 0.7. So it's less than 1:1 with fat. What is it with protein?
0.9?
No, it's 0.8. And what is it for carbohydrate? 1. So carbohydrate is the least efficient, right? For every molecule of oxygen you consume, you produce a whole molecule of CO2. So depending on what your substrate is, your CO2 production is going to change. And if your CO2 production goes up, what do you have to do? You have to breathe more to get rid of the CO2. So that's your minute ventilation, right? You need to increase your minute ventilation. Okay? So if somebody's CO2 is rising, then that's a bad thing, because then they have to increase their minute ventilation to compensate for that. They have to work harder to breathe, and that's why minute ventilation is one of these parameters that you look at. Okay? But they didn't think about the fact that these are all these things that go into that. Okay? So if you have somebody that has a high CO2 or has a high minute ventilation, you have to decide, well, why do they have a high minute ventilation? You're trying to wean them. You have to think about which of these, all of these factors that I just talked about, do they have? Well, they used to try and, for the little bit of nutritional support talk that I'm going to give, they used to talk about changing these feeding formulas in order to maximize or minimize the CO2 production, which might be really beneficial in a patient like COPD who's already having trouble getting rid of CO2, right, because of their underlying obstructive airways disease. So why not put them on what kind of diet? A high-fat diet. So they came out with a tube feeding formula called Pulmocare. Great marketing, right? Which was a high-fat formula. It wasn't pure fat, but it was a higher fat, higher concentration of fat than the usual tube feeding formulas. So the respiratory quotient, in theory, would be more advantageous. And for many years, we were given everybody on a ventilator pretty much was getting Pulmocare, especially if they had COPD or asthma or any of these problems with CO2 production. And then they finally got around to doing the the study, right? I was talking about, it takes them a long time to get around to doing the study. This all made physiologic sense, right? It's biochemistry, it makes absolute sense. When they looked at it, they found that the composition, the formula didn't really make that much difference. Whether it was a higher protein carbohydrate versus a higher fat, really didn't make that much difference in terms of weaning these patients. But they did find that something did make a difference in terms of their feeding. Do you know what that was?
Early nutrition?
No, not early. Well, no, that's still controversial, early nutrition. It was the number of calories that they got. So if the patients got overfed, if they got too many calories, they would have increased CO2 production, regardless of what the source of the calories was. It was really the total calories that was important, more so than the actual composition. So one thing that you need to be sure of when you're managing these patients on ventilators, or all critically ill patients, is you don't want to overfeed them. Probably better off erring on the side of a little underfeeding. But especially these patients that have CO2 production problems or CO2 removal problems, like a COPD patient, you don't want to overfeed them. So you have to calculate what their caloric needs are and try not to give them more than that. So how do you do that? Yeah, you asked Dina, right? What's our goal tooth feed rate? You asked the dietitian. Well, that's one way to do it. But how did they figure it out?
It's based on the body weight.
Body weight? I don't know. Is it?
That was like you need 25 calories per kilogram.
Okay, so there's a number of ways to figure out nutritional requirements. Okay, they used to use something called the Harris-Benedict equation, which was a very long, complicated equation that looked at weight and age, and then there were cofactors for different morbidities like burns or surgery or whatever, where the requirements would go up, sepsis, and they plugged it into this really big equation, and they would get a number. And the number for men and women, those formulas were completely different, those equations. If you ever get a chance to look those up, it's like the men are from Mars, women are from Venus. It's like they're on different planets. You look at them and you go, are we calculating the same thing here? Anyway, they did that for a long time. Those equations came out, I don't know how many years ago, a long time ago, 50s maybe. They used them for a long time. They found they weren't that accurate. You can actually measure oxygen consumption using a metabolic cart. And some places do that. It's difficult to do on ventilators in clinical settings, so most places don't do that. And we don't do it here. We did it for a while years ago, and it never seemed to work, and everybody sort of ignored the results, so we stopped doing it. There are places that measure oxygen consumption and determine what the caloric need is based on that. You can measure oxygen consumption using, if you happen to have a PA catheter in place, you can measure the oxygen consumption and estimate the caloric need from that. We don't, as you can see, we don't have too many PA catheters anymore. So when we had a lot of them and we're using them frequently, we would use that. So we've gotten down to more, gestalt, like body weight, certain number of calories adjusted for their clinical setting, burns, sepsis, surgery, whatever, and then estimate the caloric need. It's probably most of what it is, and I think most of what the dietitian does is they look at, all those other factors and they figure out how it should vary, as well as what would be the optimal formulas in terms of these compositions. But in terms of the overall caloric need, it's more of a ballpark, and it used to be that we would use more like 25 to 30 calories per kilo, and this is ideal body weight. Over the years, it's gone, like I said, we were probably overfeeding people. It's gotten less and less and less, and now it's probably between 20 and 25 for most patients. So that's the minute ventilation. And in terms of the other weaning parameters, what I wanted to say was, none of them are very good by themselves. And you can meet all of those criteria that we put up there and still fail extubation. You can meet none of them and be successfully extubated. So they're not absolute. not any one of them is absolute, no combination of them is absolute. And so pretty much you should never really base your decision just on those parameters, which is why I don't use them very often, okay? Because there are better ways to assess that. But that said, all of those things tell you something, so why bother doing them and if you're going to ignore them, right? Well, all of those things tell you something about your patient. I just went through the minute ventilation and went through all the possible things that could be telling you about your patient if their minute ventilation is very high and their PCO2 is 40, but their minute ventilation is 15 liters or 20 liters. That patient's got a real problem. And it could be any of one or combination of those problems that I just told you, or that we just talked about. And you need to address those problems. You need to look at those. And am I overfeeding my patient? Am I over-distending their alveoli? Are they in heart failure with very low cardiac output? What is causing this increased dead space in this patient? Do they have just really weak diaphragms and their tidal volumes are very low, so they're having to breathe really fast? And so their dead space tidal volume fraction is increased, right? Because they're not able to fill their lung as much. They have relatively more dead space with each breath. Is it just weakness? So that's another thing that we didn't mention that can lead to that. So that gives you a clue as to what may be going on with your patient as the cause of their failure. Likewise, when we look at vital capacity, that tells you something about your patient. What does that tell you? Does that correlate with anything? We talked about how do you do a vital capacity measurement. You said,
breath all the way in.
Take a really big breath in and blow it out as hard and fast as you can. Do you ever do that normally?
Yeah.
When?
When you like sigh.
When you sigh, but you're not blowing it out. You are breathing really deep. Okay, so you sigh. Is there anything else that you do that's maybe similar to a sigh breath?
Like a
Normally. What?
A sneeze.
Sneeze, very good. How about a cough? So when you cough, what do you have to do? To get a really good cough, what do you have to do? To take, if you're not taking a really big breath, can you cough hard?
No.
So if you cough from like your tidal volume, just take a normal breath and cough. Go ahead, do it. Okay. Now take as big a breath as you can and cough. So which one was more effective?
The second one.
Okay, so if you can't generate a good vital capacity, how good's your cough going to be? It's going to suck, right? Okay, so it tells you something when it gets back to the secretion management. It's actually a measurement. I said we would come back to some of that. This is it, okay? So that's a measurement that you can actually, an objective measurement, aside from the white card test, that can tell you how well that patient's going to maybe be able to generate a cough. Because if they can't get a good vital capacity, they're not going to get a good cough, be able to produce a good cough. What about the tidal volume? What does that tell you? Actually, there was one more parameter which I forgot about, and it was frequency. Just rate, respiratory rate. Knew there was a sixth one. Can't believe I forgot it. So, I guess let's do the tidal volume, and then we'll come back to frequency.
Question?
What does it tell you about your patient? The adequacy of their tidal volume, or the size of their tidal volume.
I mean, it shows that they're able to take deep breaths, which shows that a little bit.
Well, not deep breaths, it's a normal breath.
Or normal breath.
It tells you what their normal breath is going to do.
Yeah.
Okay, so what does that mean if it's low?
I mean, there's probably some kind of underlying problems not treated.
Like what?
You have too much secretions, pneumonia, dialysis.
Basically,
muscles.
when the tidal volume is low, it means the main thing, tidal volume integrates a lot of different things, okay? So the size of your tidal volume really integrates your muscle function, your inspiratory muscle strength, with everything else. Your lung compliance, your airways resistance. So it's the balance between those two things. If your inspiratory resistance or respiratory resistance goes up, or your compliance goes down, you're going to have to work harder for the same volume, right? If you can't handle that because your diaphragm or your inspiratory muscles are weak, what's going to happen? You're going to have a low tidal volume. And if you have a low tidal volume and you want to maintain the same minute ventilation to get rid of your CO2 because your brain is telling you, I don't want my CO2 to be 50, I want it to be 40, what are you going to have to do to compensate for that?
Breathe faster.
You gotta breathe faster, that's all you could do, right? Which is why when people get sick and they can't handle that and they're respiratory failure, they breathe fast. Yeah, at the other end, when they're just about ready to die, they stop breathing. But initially, what's the initial response? If they're gonna be tachypnea. Okay, so frequency or rate is really critically important. In fact, rate integrates everything. It integrates those the chemoreceptors, it integrates the respiratory muscle function, the resistance, the secretions, bronchospasm, all the resistance stuff, all the compliance stuff, and gives you the balance between those two. If that balance is good, your respiratory rate's going to be 12. A normal respiratory rate, or 10, or 8. And if it's not that good, the muscles have to work harder to compensate for all of those other factors that are going on, then your rate's going to go up, and this rate's going to be high. So actually, respiratory rate is a very key weaning parameter. In fact, to me, it's probably the single most important thing, even though the studies show rapid shallow breathing index, but what are the components of the rapid shallow breathing index? The two things that I told you that integrate everything together are the rate and tidal volume. And that's why it's such a good predictor, because that's really telling you the whole story, big picture. Okay? So we talked about all of them. We talked about vital capacity, tidal volume, frequency, NIF. That's the only one we didn't talk about. What's the NIF? It's the negative inspiratory force, how strong your inspiratory muscles are. It's a measure of inspiratory muscle function. If your muscles are weak, you can't generate a high inspiratory force or pressure. So it tells you it's yet another marker of just respiratory muscle function without integrating it with all the other stuff. Okay? So the reason why these parameters are sometimes useful, I don't use them in every patient. You've seen, we've weaned a lot, extubated a lot of patients. Have I ever asked for this in the last 3 weeks? No. Okay, when do I ask for them? Because I will ask for them sometimes. I'll ask for them when I'm having trouble weaning something. Because I'm missing something here. I need to figure out, what do I need to address that I'm not addressing? Which of these factors is causing this patient to not be weanable or extubatable? And it will give you information that if you understand the utility of each of these things, it gives you some information about how to address those and try and diagnose those problems and treat them potentially, hopefully, and then get them better, and then you'll be able to wean them. These are really pulmonary function tests. They're pulmonary function tests for intubated patients. Just like we do complete PFTs on outpatients or on inpatients that are not on ventilators, these are pulmonary function tests. That's really what they are. They tell you something about different aspects of your patient's lung function. And so if you understand them and what might be causing individual problems, you will be able to treat your patient better. Okay, so that's weaning parameters. Wow, it's going on a long time, isn't it? Talking very verbose. I don't know how much longer you want to go with this. Are there any other, so what other things? Like I said, there's like 12 to 15 things.
Acid-based
We're not
status.
even halfway through. Okay. All right, what about ABGs? Okay, everybody always brings up ABGs. So, arterial blood gases. What on the arterial blood gases are important? Well, obviously there's a lot of things important. One, you mentioned acid-base status. So, what about it?
I mean, you don't want them to be either acidic or alkalotic.
Okay, so you want their acid base to be pretty much normal, right? If it's not, what's going to happen? So say my pH is 7.2. Say I have a metabolic acidosis and my bicarb is my pH is 7.2. Are you going to be comfortable extubating that patient or trying to get him off the ventilator real soon? Why not?
Still got to try. I got to compensate for that, so they're I'm going to try and hyperventilate to try and.
Yeah, so this patient's going to have to hyperventilate in order to just compensate for this, right? For this low pH. So maybe they're going to have to breathe 30 times a minute, 25 times a minute. It's going to put extra work on that patient, even though if you correct that, they may have normal oxygenation. Their lung function may be good. Now you're just dealing with an acid-base disturbance. But if they have respiratory failure for some other reason, and then you throw this on top of it, do you really want to burden them with having to breathe faster just to compensate for this when you could probably, hopefully, correct this? And if you correct it, they won't have to breathe as much, which would be nice. So they won't have to breathe as fast. If they don't have to breathe as fast, then they probably won't tire out and go into respiratory fatigue and then respiratory failure. Okay, so what about the PCO2 on the blood gas? What do you want the PCO2 to be?
Near their baseline?
Near their baseline, good. So, not 40?
That's the baseline.
Maybe, huh? Depends on the
Some
baseline. Good.
Some of them.
Okay, so it depends on the baseline. If their PCO2 is normally 55, you don't want to get their PCO2 down to 40. Why? So their normal PCO2 is 55. I'm ventilating the patient for 2-3 days, and over a period of time, I have lowered their PCO2 to 40, which is a normal PCO2. So why is that not good?
It'll decrease their respiratory drive because normally they live at 55 and that causes them that like air hunger, so they'll want to breathe.
Okay, so what's going to happen? So when this person is extubated, if they're normally at 55 and you've got them down at 40, when they're extubated, their minute ventilation is actually going to go down because their set point in their brain is different, or in their brainstem. They're going to decrease their respiratory rate. Okay, well, that's not so bad. What's the big deal? So what's going to happen when they do that, though? What's the consequence of that?
Hypoxia.
Well, they may get more hypoxic because their CO2 is going up and they're ventilating less. So that's one thing. They may become more hypoxic and then require more oxygen. Okay, so that may be bad. Maybe you can titrate the oxygen up a little to compensate for that. What else is going to happen acutely besides the oxygen that you can't compensate for quite as easily? So chances are, if this guy normally lives, this patient normally is at 55, what's the bicarb going to be?
High.
High. So I don't know. We'll just say 30, 35. Maybe it's 35, depending on how high it is. Okay, so you've gradually brought this person down to 40, and what has their bicarb probably done during that time if their kidneys are working? For 2-3 days. It's going to go back down to a normal bicarb of 24, right? Now you're going back in this direction. Acutely, you go from 40 to 55. What's going to happen to their bicarb? Well, it's not going to change that fast, is it? So what's going to happen to their pH? It's going to go down.
Yeah.
It's going to drop. So they're going to get acutely acidotic or acidemic and acidotic. It's not a good thing either, right? So you really want to correct the acid-base problem. You want to make sure their PCO2 is near where their baseline is, whatever that baseline is. Not necessarily normal, but they're normal. Okay? And what about the PO2, the oxygen? What's an acceptable PO2 to extubate somebody? Now we're talking about extubation, not just weaning.
I mean, like, have it greater than 60, definitely. I mean,
On what FiO2?
I mean, if they're intubated, then they're probably going to be on 35, 40% FiO2. So for that person, I like their PO2 to be probably 70, 80. I mean, I like to be higher, but I mean, greater than 75.
Well, what's the minimum you'll be? What is the minimum acceptable level? Let's put it that way. Obviously, you'd like it as high as possible,
Yeah.
but what would be the minimal acceptable level that you would be willing to extubate somebody from? So it's 50%? Is that acceptable?
No, it's, I'd probably say 65.
65? FiO2.
Oh, FiO2. Sorry, I thought you were talking about.
Percent.
So I thought you were talking about an ABG.
What's the minimum
FiO2
acceptable FiO2?
40%.
40, 45,
40.
40. Karen, want to weigh in on this?
Sorry, I was trying to write down the last.
Minimum acceptable FiO2 that you would extubate somebody from.
35?
Well, it's probably somewhere between 40 and 50 usually. Almost never above 50, pretty much never above 50. Well, why not? I mean, we can get people supplemental oxygen above 50% when we extubate them, right? So why not just extubate somebody if they're on 70%?
And I think it goes back to the underlying process. So make sure the underlying process is better. So if it's still requiring them as oxygen.
Well, they were on 100, now they're on 70. That's better, isn't it?
Still a ways to go.
Not better enough?
Not better enough.
Not enough better?
Not substantially
Not
better.
good enough?
No.
Substantially better? Well, it gets down to, you know, yes, you can supply oxygen at a lower level, at higher FiO2s than 50%, but you know, the amount of reserve that you have at that point, you don't have a lot of room to negotiate. You can go, if you start at 70, you know, maybe you can get up to 80% on non-invasive, you know, on masks or vapotherm or non-invasive ventilation. Maybe you can even get up to 90 or 100%. But there's not a lot of reserve there. And generally, once you take somebody off the ventilator, their FiO2 requirement usually goes up about 10% on average. So chances are, if they're on 40, they're probably going to need about 50 when they're off the ventilator. If they start at 70, they're going to need even more than that. And then you have really no leeway. If they deteriorate from that point, you got to reintubate them. It's a big deal, right? Whereas if you start at 40 to 50, you got some room, some margin for error there for them to get worse for transiently if they have some secretions or mucus plugging, and you can work with them for a little bit and get them better. So I think that's really the main reason. Because really the movement now is to do as little invasive ventilation as possible. So ideally you want people off the ventilator, but you need to have some leeway there. So usually 40 or 50% with a PO2 of maybe 70, 65, 75, 80. There's not any hard and fast cutoff, okay? I know you guys all look for a single number and you want to know yes or no, black or white. Nothing is black and white in medicine if you haven't figured that out yet. And every intensivist and every pulmonologist you ask will give you a different answer to this question based on their personal preference, experience, but not a lot of science. There is a lot of variability. And one patient I might be willing to tolerate 50%, another I might not. Okay. All right, so ABGs, what else?
No major procedures planned for this near future.
Okay, that's not one of them that we usually discuss, but yeah, if they're going to be going for a big procedure and they're going to need sedation or they're going to have increased ventilatory requirements during or after the procedure, you certainly don't want to extubate them right before the procedure. They go into the operating room, you don't want to extubate them at that point because they're just going to get intubated anyway. Okay, what else? So we're about halfway there, although the things we've talked about are probably the most involved. So the other ones go faster. Think of those other things, they go faster. So start thinking organ systems. What other organ systems can be involved or cause problems with respiratory function?
So
Or even respiratory organ system. We talk about the primary, you know, usually the underlying process, we're talking about the underlying lung disease. So you want to treat that really aggressively, whether it's pneumonia, asthma, COPD, whatever. Bronchodilators, steroids if they need it, whatever. You want to treat that stuff really aggressively. Most of this talk has to do with non-pulmonary stuff, though, other factors which have an effect on whether somebody is going to be weanable, extubatable, or be in respiratory failure. So what are some other things that can cause respiratory failure, maybe not directly associated with the lungs?
MI, like cardiac issues?
Okay, well, we talked about the cardiac
Sorry.
hemodynamically stable. I think we mixed those
Sepsis.
things together. Sepsis
Severe
can,
sepsis.
but you know, you're not, when we extubate plenty of people who are septic, depending on how septic they are. If they're in septic shock, we usually don't.
Neuromuscular problems?
Okay, so neuromuscular problems. So what neuromuscular problems might affect your ability to read?
So ALS?
Okay, so neuromuscular. Okay, so ALS, what else? So some people have ALS. Most people that develop respiratory failure with ALS, you kind of know they have ALS, right? It's kind of the end stage of that process. They don't just develop ALS and go to respiratory failure acutely usually. But that is obviously a cause of respiratory failure, and that person is never going to probably be able to read because it's a progressive decline. It doesn't get better, at least until somebody comes up with a good treatment. Other things, though, that can affect neuromuscular function besides
Myasthenia
ALS?
gravis.
Okay, so myasthenia. So myasthenia gravis definitely can cause respiratory failure. And you may or may not know, you know, sometimes those people will present in respiratory failure for the first time. So it's not common, but it can happen. So you need to start thinking about those things, especially if those other things that I was talking about where you're trying to assess their muscle function and it's really poor, and you don't have a good explanation for it, you need to start thinking of these things. Is that what's causing them to be not weanable? Maybe they came in with pneumonia, and now the pneumonia is better, but you still can't get them off the ventilator because they're weak. Why are they still weak? Is it because they were septic and they're weak and they've been on a ventilator a long time? Or is it because maybe they had some neuromuscular problem to begin with that caused them to aspirate and develop the pneumonia, and now they've still got the neuromuscular problem that you didn't recognize, right? So myasthenia is one. What else? Guillain-Barré, another one. Okay. Anything else?
Have like muscular dystrophy, but that would be more common.
That's more chronic, usually muscular dystrophy.
Tetanus.
Tetanus.
Botulism.
Okay. Botulism.
Isn't there like neuropathy of what our patient has right now? Neuropathy.
Critical illness
Yeah.
polyneuropathy.
Yeah.
Okay, so, or myopathy. You get both or a combination. Yes, our patient in 15 has what we think is very, very profound critical illness, neuropathy, and myopathy. She can move her hand like that. Okay, so how do you diagnose that? What causes that?
Steroids help.
Steroids are associated with it.
Steroids don't help.
They
Steroids
cause it.
actually
They help cause it. I don't
Yes,
know, I use the wrong
steroids
word.
may be one of the things that causes it,
Yeah.
contributes to it. What else?
Prolonged intubation.
They usually have prolonged intubation. Renal failure, it's a predisposition. Steroids. Some people think glycemic control or glycemic control. The original intensive insulin therapy trials showed that they had a reduction in critical illness polyneuropathy when they had tight glucose control. It's controversial. Turns out that in the absence of tight glucose control, there is mitochondrial dysfunction, which may be the cause of that. Or that they've tried to look into, they've done studies to try and see whether that's the problem. And it may be, or part of the problem. People that have been on neuromuscular blockers for prolonged periods of time are at high risk for it. This particular patient in 15 had pretty much almost every risk factor. She was on neuromuscular blockers for almost a week. She was on very high dose steroids, which caused her glucose to control to be less than optimal, although it was pretty good because we had her on an insulin drip. She did not have renal failure. It's about the only thing she didn't have. She's been sick for a long time. She's been on the ventilator for almost 2 months. So it can be a really, as you can see, it can be a horrible problem. It may not ever recover. And if it does recover, it can take weeks to months to a year. It's for her, it's profound that she has it. I mean, it's not always that profound. It could be a year, and she may never recover. So you always have to keep that in mind. There are drugs that can affect neuromuscular function. Aminoglycosides. She's been on aminoglycosides also. Can also cause a neuropathy and a myopathy. Steroids alone can cause a myopathy. This is neuropathy. It's actually both. Okay? So you have to think about these things. Obviously we've thought about it, we've diagnosed it. Unfortunately, there's no good treatment for that. There is treatment for some of these other things. Anything else?
Spinal cord injury.
Okay, spinal cord injury. Particularly at what level?
Cervical 3, 4, 5.
3, 4, 5 keeps the diaphragm alive, right? So people with C2 fractures, most of them don't survive. If they have a spinal cord that's C2, they die out in the field. Below that level, you may have varying degrees. If you have a C5, you will have some diaphragmatic function. Some of those people don't need to be on ventilators for through C3s usually do, almost always. Okay. All right. So we talked about neuromuscular function. What else? We talked about nutrition. So neuromuscular. We talked about nutrition. We talked about what else? What other things? So you want to make sure your patients are adequately nourished, otherwise they're going to get weak. So we said don't overfeed, but you've got to give them enough nutrition to support their muscle function and their other protein metabolism and other function. Okay, what else?
Fluid status?
Fluid status, okay. So what about fluid status?
You don't really want them overloaded, but you don't want them too dry. But you're more worried about being overloaded though.
Okay, so the term is,
You believe it?
like is a term that I learned when I was learning this. You want them optimally dry. That means you want them as dry as possible, but still adequate perfusion, right? And they've shown that using conservative fluid management after patients have been resuscitated and they're hemodynamically stable and their sepsis has resolved or their shock has resolved, that minimizing their fluid and actually having them operate on the drier side or the lower side of the Frank-Starling curve, if they have adequate cardiac function and adequate perfusion, those patients do better, and you can get them off the ventilator faster, get fewer ventilator days, and get them out of the ICU faster. And that's been shown in ARDS patients as well. But again, it's after the initial resuscitation period is over, that's when you want to start trying to mobilize and get rid of that fluid, okay? And so you want to diurese those patients. You want them optimally dry as possible, but still perfusing and with an adequate cardiac output and renal perfusion. Okay. So that's optimally dry, and that can be pretty dry. In the ARDSNet patients in the protocol where they looked at liberal versus conservative fluid strategies, they were, if you look at that paper, they were shooting for CVPs of less than 5 in everybody in the conservative fluid group. Okay, so next.
Electrolytes?
Okay, electrolytes. Doing good. Electrolytes. I guess you actually learned something the last time you were this
Yeah.
Or do you have your notes out there?
Not unfortunately.
All right, I don't know what I did there. Electrolytes. Okay, so what electrolytes are important? To breathing and muscle function. It's muscles, right?
Yeah.
So potassium, calcium, magnesium, phosphorus. Those are the 4, right? Potassium, magnesium, calcium, phosphorus. So you want to normalize the electrolytes. You want them normal, because you want to have adequate electrolytes for their normal muscle function. Okay, what else? That was a quick one. Most of them, you're getting there.
Close.
Come on, man. Can I erase some of this stuff?
Yeah.
Should I just stay down here?
I know this kind of covered underneath the other ones, like febrile.
Well, fever, I mean, we do extubate people that are
Right.
septic. It does increase minute ventilation for ventilatory requirements. Yeah, I mean, if somebody's got a fever of 105 or malignant hyperthermia or serotonin syndrome or something like that, you're going to wait for them to cool down before you extubate them because it's going to increase their metabolic demand and their respiratory demands.
Maybe like frequent arrhythmias, and you think you have to keep shocking them, like post-cardiac arrest patients?
Okay, so arrhythmias gets into the cardiac again.
Yeah, it's more.
But, yeah, so you want to control their arrhythmias, you want to control their heart rate. If they're an AFib, you want to control the rate or get them to convert. Okay, anything else? Any other organ systems? Any other things? I can think of probably three more things.
I mean, neurologic, if they have like brain trauma or something, you want to decrease their ICP, and you're doing all different maneuvers, but I guess that's more underlying process probably.
Yeah.
And number
Other
11.
organs.
Trying to find the number 11.
So, I think GI system, something about that, but
Well, think about the patient in bed 15. You guys weren't here when she first came in. We had a big problem.
so
with her.
vasculitis.
No. Well, she had, yeah,
She has
that's
that.
why.
So
That's
anemia,
the
like
problem.
the oxygenation.
Profound anemia,
problems.
right? Okay, so does anemia play a role in any of this?
I mean, increase your lung breathing if you're hypoxic.
Well,
I mean, if you
plus
have
your
your
oxygen carrying capacity is
low.
down, your O2 content of your blood is low. So yeah, anemia can make a big difference, right? So number 11, we'll put anemia. So what do you want the hemoglobin to be?
Greater than 7.
I know, you look at the TRIC trial, looking at transfusion requirements in critically ill patients, they said, transfusion trigger of 7 is just as good as 10 or better. Is that always true?
No.
When isn't it true?
I mean, coronary patients, people having like
Okay, so-
coronary ischemia, you probably keep them greater than 10.
Okay, so coronary patients, they say keep them at 10 or higher. There's not a lot of data for that. They
Yeah.
excluded those patients from this trial, from the TRIC trial. So who knows? Do they really need that? I don't know. There is some data, but not great data on
Yeah.
that. But generally, they say if they have active ischemia, not just somebody with a history of coronary disease.
Yeah.
If they have active ischemic heart disease, yeah, they probably should have a higher hemoglobin. Anybody else?
Septic patients.
Okay, septic patients. So in the early goal-directed therapy, in spite of the TRIC trial showing a hemoglobin of 7, the transfusion trigger in septic patients in the early goal-directed therapy was 10 if the SCVO2 is low. So if they are showing signs of inadequate oxygen delivery manifested by either a low SCVO2 or a low mixed venous O2, SVO2, then those patients should have a higher hemoglobin of 10. It's very controversial because everybody goes, well, what about the TRIC trial? Well, the TRIC trial had a small number of septic patients, but probably not enough to answer the question. And in River's study, that was a big part of the intervention that they did, was they gave them blood. So you either have to buy into it or not buy into it until better evidence comes along. Some of the more recent evidence that's been published in the last year suggests that yes, in fact, patients who are septic who get transfused to that higher number actually do better than the ones that are not. So there is some emerging data. It's not prospective randomized trial, but retrospective trials would show, or suggest that that's the case, which would go along with what Rivers did. So at this point, I think it's up in the air. I think if you're going to use the early goal-directed therapy, you have to follow the protocol, or else don't do any of it. You can't just pick and choose, because nobody really knows. Okay, next. The other thing is, if you have a patient with bad COPD, really bad COPD, what's a normal response to COPD in terms of hemoglobin? It goes up. They become polycythemic, right? So a normal hemoglobin in a bad COPD patient might be 16 or 17 instead of 14 or 15. So now when you use a transfusion trigger of 7 in that patient, that's less than half of their normal carrying capacity. Okay, so is that enough? I don't know the answer to that. What I can tell you is, in that patient who I'm having trouble weaning, if I can't find any other factors, I'll probably give them blood. Do I have data for that? No. It's just makes sense. Which is a lot of what we end up having to do in medicine, because there's not a lot of data for most of what we do. That patient, then 15, I mean, her hemoglobin was 3.9. I think there was no question she needed more blood. So, unfortunately, because she was a Jehovah's Witness, we couldn't give it. Okay, so what else? So we talked about anemia, electrolytes, other organ systems. Are there any other organs that we haven't discussed? Nobody ever comes up with this one.
Major endocrine issues.
So what endocrine issues?
So, myxedema coma.
Okay, so severe hypothyroidism, myxedema coma. What does that do? Can that affect your respiratory? Can it cause respiratory failure? Can, yeah, definitely. So they can get they can get muscle weakness. It may also throw off their chemoreceptor set point too, hypoventilate. Okay, so hypothyroidism, anything else? Any other endocrine abnormalities? Maybe going into endocrinology?
Maybe. Thyroid storm?
Maybe. Thyroid storm, not usually. I mean, increases metabolic demands, but you're not going to extubate somebody in the middle of thyroid storm. No. Anything else?
If they're DKA, and they're still in the middle of DKA, they get admitted for whatever reason.
Well, that gets to the acidosis.
Yeah.
Again, glycemic control may or may not play a role in critical illness polyneuropathy. There's another endocrine abnormality.
Renal insufficiency.
Renal insufficiency.
Yeah.
Good. So that causes weakness, right? Muscle weakness. So that's another thing that sometimes you totally overlook because it's not easy to diagnose, particularly in a critically ill patient. Okay, so cortisol. Increased cortisol. Okay, so the last thing probably, I think we've combined a few things, so we're probably down to the last one that I can think of offhand. Well, or the last two. One of them we talked about intrinsic lung stuff, like treating bronchospasm, things like that. But there's also treating extrinsic factors that impair lung function, mechanical factors. So what, can you think of any factors that might do that?
Abdominal compartments.
Okay, great. Abdominal, so I'm going to erase this. Got this whole list here. Just erased them all. Hopefully you've written them all down. Right up to 13, 14, right?
Yeah.
So I call this, I group this as extrinsic factors. Okay. Basically, the extrinsic factors that impair lung function or potentially can impair lung function. Abdominal compartment syndrome is a great one. Okay. Very severe abdominal distension. What happens? How does that impair lung function?
presses the diaphragm.
Yeah, pushes the diaphragms up. The diaphragms can't contract normally, can't descend against that extra pressure, right? So not just abdominal compartment syndrome though, anything that really distends the diaphragm. So you don't have to necessarily have a compartment syndrome, as just severe abdominal distension can do it. So what other things can do it besides compartment syndrome?
Liver tumor.
Yeah, you could have a severe tumor, liver, huge liver, I suppose. What else?
Ascites.
Ascites, okay, which are going to affect both diaphragms. So ascites, hence ascites, definitely. Well, yeah, I'm sure you've seen that, right? In these really bad cirrhotics with really tense ascites, you know, their tidal volumes are really small because their diaphragms are pushed up. They can't breathe. They go into respiratory failure sometimes. So what do you do for that?
Diuresis
You
tap.
You tap their belly, right? You take off 4 or 5 liters, and they look a lot better after that, usually, right? Until their blood pressure crashes. Okay, and a compartment syndrome, you have to treat it, whatever the cause is, right? So if you don't take them to the operating room, open up their belly. What else?
Constipation.
Okay, constipation. Okay, so you laugh, like you've heard this story, and that's why you brought it up. Right? So I'll tell the stories. And I haven't told any stories in this lecture, right? I gotta tell at least one story in the lecture. Okay, so this is the last story, and the last part of the end of the lecture, really. When I had a pulmonary practice, I had an office up by St. Francis Hospital, which is no longer in existence, up in the foothills there. And I got a phone call one day. I was in my office, got a phone call from the emergency room. The ER doctor said, hey, I've got this, you know, this kind of elderly Hispanic lady who is going into looks like she's in respiratory failure, and I'm going to intubate her. Can you come and see her? And I said, sure, I'll come and see her. By the time I got there, she was already intubated. She was short, you know, probably less than 5 feet. And when I was examining her abdomen was very distended. Not really super tender, but distended, didn't seem like fluid. And I talked to the family who had brought her in, and it turned out that she had not had bowel movement in like several days. I said she's been very constipated, because I was trying to find out why is she so distended. Her chest x-ray really didn't show much. She didn't have any lung problems, but she did have COPD. She had a history of COPD. She had been a smoker. And so I, you know, was examining her abdomen, and I said, well, let's give her an enema, you know. So, you know, we transported the patient up to the ICU, ordered an enema, come in the next, she has voluminous bowel movement during the night, come in the next morning, her abdomen's soft, it's not tender, her lungs sound the same. She didn't really sound like she had a lot of bronchospasm, even though those ER docs said, you know, it's just COPD exacerbation because she had a history of COPD and she's in respiratory failure, right? So she seemed fine. I went through all these things that we've done, you know, talked about today, and I said, you know, I don't see any reason why she shouldn't be extubated, and we did a, you know, a breathing trial, and we extubated her, and she did fine, okay? So she went home. I didn't really follow her. She didn't have that bad a COPD. And I didn't hear about it again for several months. And then about, I don't know, 3 or 4 months later, I get a phone call from the emergency room at St. Francis again. And they say that this patient is there, and she's in respiratory failure, and they're getting ready to intubate her. And I said, well, wait, stop. You know, don't intubate her yet. And I said, you know, ask her or her family if she has been really constipated and is her abdomen really distended. And they went, you know, and they asked, and yes, sure enough, it was the same story. She had been very constipated, hadn't had a bowel movement in several days, and yes, she was in fact pretty distended. And so I said, well, don't intubate her, just give her an enema. And they thought I was absolutely out of my mind. Here's this patient who's basically with impending respiratory failure, and I'm telling them to give her an enema and not to intubate. But I convinced them to do that, and they did give her an enema, and she had a big bowel movement. She was fine, and she went home from the emergency room. got admitted. Okay, so that's an example of how an extrinsic factor, can affect diaphragmatic function, respiratory muscle function. Okay. Now, has it ever happened again? Actually, yeah, it's happened in here a few times in the ICU where we've had similar situations. Obviously not where we just extubated them immediately, but people that have been on a ventilator and we were having trouble weaning them, and that was the problem. So yeah, it can make a big difference, and you have to think about it. Anything else within the chest cavity, extrinsic to the lungs?
Rib fractures.
Okay, so rib fractures, flailed chest, multiple rib fractures. Rib fractures is causing pain and splinting. Anything else that might be associated with rib fractures?
Pneumothorax.
Pneumothorax. So pneumothorax is going to impair lung function. Tension pneumothorax, even non-tension pneumothorax. Anything else?
Cardiac tamponade.
Pleural effusion. So large pleural effusion. So sometimes you just need to tap those effusions, and that's enough to be able to extubate the patient. So if they have large effusions, you want to tap those if you're having trouble extubating them or weaning them. Pericardial tamponade obviously goes back to hemodynamic and cardiac stability. But yeah, so you want to drain that and improve that underlying problem. Okay, so I think that's enough. We've spent a long time here. I'm exhausted. So you're probably exhausted. But you got to turn it off for a while. These guys had to sit here.